of Ophthalmology session, and the title is the updates on the diagnosis and management of Asian eye diseases. We know that there's quite a lot of diseases that specifically affect Asian people, so we just hope to have a good session, really exploring some of the updates on the diagnoses and management of these diseases. I'll start first, and the first up is my talk, and it is on non-invasive imaging for polypoidal choroidal vasculopathy. Yes, actually, it's a continuation of yesterday's talk. It's a bit more detailed because I have more time here today. So thank you for coming, for those that are coming here. We wanted to talk a little bit about the diagnosis and management of PCV with non-invasive imaging. So you can see that this is the outline. Essentially, we're looking at how we can classify AMD, typical AMD versus PCV. And we want to look at the multimodal imaging for the diagnosis of PCV. We want to differentiate PCV from typical AMD. And we want to have multimodal imaging to monitor treatment response in PCV. So firstly, we need to know some background. I mean, this is everybody knows that PCV is an Asian subtype of AMD. It is the identification of PCV lesion allows the differentiation of PCV from typical AMD and has implications for treatment because, of course, with PCV, you may need second-line therapy like PDT or focal laser. PCV affects people in all ethnicities, but more prevalent in Asians, and is up to even 55% of Asians have PCV. It is a subtype of wet AMD, and you can see that it's characterized by abnormal choroidal vascular networks ending in polyps, and it's considered to be a subtype of wet AMD. The clinical features include serosanguinous maculopathy, few or no drusen. You can see the imaging features look like polypoidal dilation, the branching vascular network, and a thickened choroid and peripapillary lesions. This is the example of a multimodal imaging of PCV. You can see there's everything from color fundus photos to multicolor to fundus autofluorescence. And you can see the OCT and is especially useful for the diagnosis of PCV. Of course, FFA is also done, and ICGA is the gold standard. And you can always see that polypoidal lesions consist of the polypoidal lesions themselves and the adjacent branching vascular network that you can see in the blue arrows. ICGA remains the gold standard for PCV diagnosis. And you can see here in the early regions, you can get the hyperfluorescent lesions, your orange subretinal nodule, massive submacular hemorrhages, a pulsatile polyp, and you can see at that bottom, that polyp is pulsatile, nodular stereoscopic appearance, hypofluorescent halo, and branching vascular network. But ICGA, of course, is costly, invasive, and a lot of places don't have it. There's example like the Heidelberg Spectralis costs $50,000 to purchase. The cost of the dye is a lot. And of course, it's off-label in some countries. And ICG has some risks, which includes, cardiac arrest, and it needs a crash cart when you do ICGA. So what are the alternatives to ICGA imaging for PCV diagnoses? You can use color fundus photos, multicolor imaging, OCT, as well as fluorescein and OCTA. Today we will be focusing more on the multicolor, OCT, and OCTA. You can see how to differentiate between typical AMD and PCV. In typical AMD, you can see the ICG has a plaque, whereas in PCV, you can see these pinpoint hypercyanescent images with a branching vascular network. And what happens when you don't have ICGA? You can see the OCTA helps you a lot because on the left, in typical AMD, you get a multi-layered PED, but on the right, you can see a peaked PED with a branching vascular network. Color fundus photo and multicolor imaging can help, and we published a paper looking at PCV characteristics, and this can be identified by subretinal red-greenish nodules, a fibrovascular PED, massive subretinal hemorrhage, and a peripapillary location. And you can see there's no large drusen, which is a marked feature of PCV versus typical AMD. So what is multicolor imaging? Multicolor imaging is using a confocal scanning laser ophthalmoscope and three different wavelengths of light superimposed on each other to form a multicolor image. And we also looked at how we can diagnose PCV based on multicolor imaging and color fundus photography. And you can see that in our case, the polypoidal lesion is detected in about 50% of all cases, and both modalities, both color fundus photo and multicolor, are comparable for the detection of pathological features of PCV. But it only does it in half the cases, so that's not great. However, OCT is much more specific and sensitive, and the presence of these three features you can see here: multiple PEDs, the sharp peaked PED, the PED notch, and a PED notch is actually the notch when you go on the curvature on the cross-section of the PED. So when there's a large PED, it's when there's a dimple on the PED. A PED notch on fast imaging is different because that looks like sort of the inside of a bean on the on fast, but the notch on the OCT is a little bit different of a sign. So anyways, you can see here also the rounded hyporeflective area with the polyp lumen that you can see in some of these pictures over here. These are also very typical of PCV. So you can see that OCT is an effective alternative to ICGA, and it's also widely available, and the high sensitivity and specificity is used when it's used alone to diagnose PCV. And then you can see we've already come up with a nomenclature by the APOIS PCV work group, and these are the few characteristics, like I mentioned before, that is typical of PCV: the sub-RPE ring lesion, the on-fast OCT complex, the sharp peaked PED, and the minor criteria is the complex or multilobular PED, the thick choroid, the double layer sign, and the fluid compartment. So when you combine modalities, you can even get more sensitivity. So a combination of color fundus photo and OCT can also help the diagnosis. And in this paper by one of our colleagues, Vorapon, she has shown that there's high sensitivity for PCV diagnosis when you combine both color fundus photos as well as OCT. And the addition of FFA did not help the diagnosis of PCV. So one of the most common PCVs have branching vascular networks is with a type 1 neovascularization, which is underneath the RPE. But PCV can also occur with other types of neovascularizations. You can see here, this is the PCV lesion. This is the type 1 branching vascular network. In the secondly, you can also get PCV with a type 2 network, and in this case, you can see the PCV lesion here and the subretinal hyperreflective material that is the type 2 lesion. So the STREM is in the yellow arrows, and the green arrow shows the PCV. Also, you can get PCV in combination with RAP, a type 3 lesion. So in this case, you can see this is the RAP lesion, which is the intraretinal lesion, and you can see there's an adjacent PCV underneath it. And what else can we have in our armamentarium of multimodal imaging? We have OCTA also, and OCTA can help with the diagnosis. You can see the OCTA here that shows a hyperflow lesion where the PCV is and an adjacent branching vascular network. And the PCV is here seen as a hyperflow structure on OCTA, but this is not always the case. In 75%, actually, the polypoidal lesion on OCTA may show up as a hypoflow structure and not a hyper one. And this is really because I think the flow in the polyps may not be fast enough to reach the threshold of the OCTA, and hence the BVN is always showing up, but then the polypoidal lesion itself may not. And you can see that's what I mentioned. It's a hypoflow structure, so it's not bright in 75% of the cases, but in 25% of the cases, it is bright. And the BVN is always quite well seen on OCTA. So when you combine the detection and the diagnosis of PCV with OCT and OCTA, you can see these 2 out of 3 signs where we looked at, which is a PED, a notch or narrow pigment epithelial detachment around pigment epithelial structure, as well as on OCTA, the cross-sectional OCTA is the most useful one because you can see the hyperflow signal. It may or may not always translate to the on-fast OCTA, but that depends on your algorithm. So you can see this actually achieves an 82.6 sensitivity and 100% specificity for detecting PCV. So together, these two modalities are the way forward for non-invasive imaging. And not only that, but multimodal imaging can also monitor response to PCV therapy. To therapy in PCV. This is a 50-year-old Chinese male. He had left blurring of vision. You can see a nice peak PED with a little bit of the ring treat the patient, what happens? So at baseline, he's 619, 3 aflibercept later, and you see there's very nice regression. The polypoidal lesion is gone, even though there's some branching vascular network still there. So this is complete polypoidal regression, where the polyp goes away on ICGA, the PED flattens, and there's fluid resolution. And however, you can see that when we image polypoidal closure with ICG, it is an important outcome measure. You can see some of the different outcomes. In this case, after 3 aflibercept injections, the polyps are still there and they're persistently perfused. Whereas when you compare the case I showed you before, after 3 aflibercept injections, in that case, the polyp totally regressed, and these are closed polypoidal lesions. And why is polypoidal lesion closure an important outcome? It is an outcome that has not been recognized so many times with the treatment of PCV in the past before, because people just look at visual acuity and OCT and fluid. However, it is an important outcome because we know that open polypoidal lesions have been associated with devastating visual outcomes due to large hemorrhagic PED, submacular bleeds, breakthrough vitreous hemorrhage, and RPE rips, which are less common, but still a problem. So treatment implications for persistently perfused polypoidal lesions include more intensive anti-VEGF treatment to achieve polypoidal closure, long-term maintenance of anti-VEGF therapy, and a surveillance to make sure that new polypoidal lesions are not appearing. Also, to consider adding combination therapy with either PDT or for extrafoveal lesions, focal laser, and the need for more vigilant monitoring. You can see in this case, apart from what we presented before, where OCT can be used to diagnose PCV, it can also be used to assess the polypoidal lesion status after treatment. And some of the major criteria is if the polypoidal lesion has a dense hyperreflective appearance, like you can see on the top right picture at the follow-up of 12 months, and the absence of SRF and the absence of the subretinal hyperreflective ring, this shows that the polypoidal lesion is closed. Minor criteria include the distinct RPE above the PED, the absent PED, absence of IRF, presence of fibrovascular PED, and a decreasing maximum PED height and increasing hyperreflectivity of PED contents. So in summary, you can see that multimodal imaging can not only diagnose PCV and differentiate it from typical AMD, but half of the PCV can be picked up with color fundus photo and multicolor imaging alone. With the addition of OCT, you can get high sensitivity and specificity to pick up PCV. FFA shows some features of PCV, like its activity and leakage, but it's less specific for the diagnosis of PCV. And we can use multimodal imaging to monitor the treatment response in PCV, and the activity of PCV can be detected on OCT, FFA, and ICGA, and polypoidal inactivation or regression can be detected on OCT, OCTA, and ICGA. So future considerations: can our multimodal imaging improve to actually replace ICG as a gold standard for PCV diagnosis? It has some way to go, because at the moment, the polypoidal lesions are not always detected as hyperflow lesions, and so some advances in OCTA to better detect PCV lesions would be better algorithms. So the reason now some PCVs are not detected is because the flow is too slow, and the OCTA needs a particular threshold of flow to be exceeded before it appears as a white pixel instead of a black pixel. So if you change the thresholding of the OCTA, then it's possible to get a white pixel on lower flow, and also then this is what thresholding is about. And also we can identify more non-invasive biomarkers to predict the progression and monitor the response. All in all, thank you very much for this, and we invite you to APVRS in Singapore, which is happening in November, and also there's a Fellows Vitreous Surgery course. With that, I'll take any questions if there is from the floor. Thank you very much.
Thanks, Anna. So, shall we keep the questions to the end?
Yeah, or we can do, because there's some time, so we can do it, because I think each topic is quite different.
Sure.
If there's any questions from the floor?
Maybe I'll start with a question first, Anna.
Yes.
I mean, pardon me, because I am, not so well versed in medical retina now. Now that I'm a bit more of a glaucoma person. So, can you explain what is the reason for the sharp PED and the notch in the PED, right? That you take an OCT that is so specific to PCV.
Yeah, so the peak PED is usually because the polypoidal lesions, which increasingly we know are not actually polyps. So the old word of polyp, whereby it's like a protrusion or a tissue protrusion, is actually a false word. Now people use this word called aneurysmal dilatation of the lesion. So essentially it's a mini aneurysm that comes out from a choroidal vessel. And I think when it has this aneurysm and it sort of grows into a sort of a bigger aneurysm, then it lifts the above RPE into this peak configuration. And this is why also sometimes we know that PCVs grow on the undersurface of the RPE, and it's actually grown above Brooks and underneath RPE, in that RPE Brooks space. And that is why when it grows on the underneath surface of the PED, in a large serous PED, it makes that little notch, which is that little bump on the PED. So I think it's these reasons why the appearance looks quite like that, and I think histology increasingly has proven that's the case also.
Thanks for that. So based on your current practice, do you see that, based on your talk, I can see that there is a lot of potential with the use of OCTA. Do you find that the frequency of you using ICGA now is getting lesser and lesser? And do you ever do away with it?
So I think that was a question also yesterday when we were having the retinal subspecialty day. How much do we need traditional angiography anymore? So I think it's not totally redundant, but definitely its use is reducing, because when you use OCTA and when the membranes are clearly there, when all the features of polyps are like there, you can definitely diagnose both typical AMD, PCV, and a lot of AMDs based on OCTA if the OCTA shows the lesion clearly. However, when the OCTA does not show the lesion, sometimes the OCTA is not 100% specific, so you may need to go and do angiography when there's no lesion seen. For things like planning your PDT, however, I think ICG is still an important modality, because when you plan FFA and ICG, because when you plan a PDT, you want to make sure you get the entire lesion, the entire branching vascular network, and PCV next to it. And also you want to make sure that you see where the areas are leaking, which is on the fluorescein. So there's still examples where angiogram is still important. However, for the diagnosis of typical AMD, a lot of times when it's clear on OCTA, you may not need to have angiogram anymore.
Great, thank you. Yes, sir.
Great presentation. Just a couple of questions. One thing is, how different is PCV with AMD? Because we still treat with the same drugs.
True. True.
This thing, and still we keep on treating, and when do you stop treating them? Because if they are responding, regressing, I can understand. But there are many times we find that because of the blood, the hemorrhage, we have hardly been able to assess them. As long as there is no hemorrhage, all these multimodal imaging have some say. But the moment you get a large hemorrhage, then what do you do?
So I think when you have a large hemorrhage, then it's game over. Actually, because once you have a large hemorrhage, you either do a pneumatic displacement or you have to do a vitrectomy to displace the hemorrhage if you can, and if it's a subretinal hemorrhage, right? But if it is a PED, a sub-RPE hemorrhage, or it's a vitreous hemorrhage, then you just have to deal with it when it's there. But the idea of multimodal imaging is picking up the open polypoidal lesions before they bleed, right? And actually we know that we had a randomized controlled trial that if you do intensive monthly anti-VEGF treatment after 3 loading doses for another 3 loading doses, 30% more of your polypoidal lesions are closed. So in this case, aiming even before the bleed happens to close those polypoidal lesions, be it doing it with intensive anti-VEGF or addition of PDT or addition of focal laser to some of the lesions that are more peripheral, these things stop the bleeds from happening. Because once the bleeds happen, it's like you said, it's game over already.
Any choice of anti-VEGF you would like?
So obviously the longer acting anti-VEGFs, and now I've been using faricimab a lot, and that has, and both aflibercept and faricimab actually both are very good with PED treatment, so they actually flatten out the PED much better than Lucentis and Avastin. And I think actually there's been a lot of papers and a lot of presentations on Beovu, brolucizumab, and that as a third-line therapy, obviously, really looking clearly for the IOI signs and everything. But brolucizumab, for those that are resistant to faricimab and aflibercept, have actually been shown to really help reduce the PED size and get the disease under control. So I think these are all options that we have, and as we expand to more and more anti-VEGFs, we'll be able to treat this better. But I think looking for these polypoidal lesions and aiming to close them, and that brings you to the other point, when do you stop, right? So actually for polypoidal lesions, unlike AMD that always sort of like rumbles on for ages, if you are able to, when you see a polypoidal lesion that has closed and has flattened, and there's a BVN that's very slowly leaking, in a lot of those cases, if you stop, you can actually, stop treatment and just watch them closely. Yeah. Okay, anyways, we're running out of time. My next speaker, so we have to apologize on behalf of Dr. Bofena because he fell ill and was not able to travel here for his talk. And so we wish him all the best. But the next speaker we have is Associate Professor Victor Koh from the National University Hospital, who will be talking to us about updates and management of angle closure glaucoma.
Thanks, Anna. Thank you. Good morning. Thank you so much for waking up so early to join us for this particular session.
Is
so,
the mic? Is
can
it
you
on?
hear me? Yep, okay, great. So I thought I will show you where I work. Over here is a landscape view of the hospital. To your left, if you can see where my mouse is where the hospital is. Singapore is very small, unlike India or Calcutta, so we don't have a lot of land. So a lot of our offices and hospitals are built very tall. So that's where the hospital is, and that's where the university is to the right. So it's all within walking distances, and this is one of the tertiary institutions in Singapore. Today, I'll be speaking a little bit more about angle closure glaucoma, something that is a bit more common in Asia and amongst Chinese as well. These are my disclosure, a couple of invention disclosures and patents that's relevant to the content of today's talk. And this is the scope that I will go through and have some patience with me as I go through what angle closure is and how we intend to diagnose this through imaging, as well as how we manage them using evidence-based medicine. So what is the spectrum of angle closure disease? And throughout the content of today's talk, I will be referring to this spectrum of angle closure disease and how we diagnose them, as well as how we treat them based on how severe the condition is. Firstly, you will have the asymptomatic patients who have narrow angles. We call this occludable angles. In other words, the synechia hasn't formed, pressures are normal, and the optic nerve function is normal. This could sometimes be a first world problem because we detect them way too early, and now they have to be on follow-up in the eye clinics. If you don't do anything about this, a small proportion of these patients progress to what we call primary angle closure. This is where there is evidence of synechia closure at the angles. The pressure is starting to creep up. Sometimes you don't get the pressure creeping up, but you get peripheral anterior synechia. But once this is established, the condition becomes primary angle closure. The nerve, if you will notice, is still not damaged. There's no structural or functional deficit in these patients. This is a small subset and subgroup of patients, and if you catch them now, while they are still asymptomatic and with no functional deficit, the outcome can still be very, very good. Now, the problem is that you don't catch them at the first and second phase, and they progress. As the pressure starts to come, up and they start to exert pressure onto the optic nerve, and the optic nerve start to crumble, have structural and functional deficit. You enter what is called primary angle closure glaucoma, or in the sometimes you hear this term called chronic angle closure glaucoma. These are people where the pressure is starting to be elevated, and now they have both structural and functional deficit on the optic nerve. So throughout the course of today's talk, I'll be referring to PACS, PAC, and PACG. How do we treat each and every one of this severity of primary angle closure disease? So let's maybe go into investigations and what can we do to diagnose this condition. We know how notorious it is to detect angle closure. It is not so simple. The Van Herrick rule or the Van Herrick screening tool is still very good. If you could use a slit and cast it to the angle, cast it to the close to the limbus of the angle, you'll be able to detect angle closure. But the gold standard, and it is still the gold standard, is gonioscopy. Gonioscopy, however, is subjective, requires practice, and it can be variable. So different people can see different things through gonioscopy. You can perform photogonioscopy, like in this particular tool that we developed, that can be used by the clinician to detect dynamic changes in the angle through indentation gonioscopy. But my favorite tool so far has been the anterior segment OCT, and I'll show you why this is particularly useful and gives you a good cross section as well as the mechanism of angle closure that I use now to guide my management of angle closure. What is the advantages of anterior segment OCT? I think I won't put too much emphasis on this. We all know that it is easy to use, the non-contact is rapid, it is objective, but it is a little bit more expensive. You can't visualize the ciliary body. This ciliary body is hiding behind the iris, and it plays a big part, and we know more and more now that the ciliary body position, the size of the ciliary body, plays a big part in angle closure. It is not dynamic. You can't indent, you can't differentiate it, at least in theory, can't differentiate between appositional or synachial angle closure. The ultrasound biomicroscopy is something that you might have in your practice. It is particularly useful in visualizing structures behind the iris, such as the ciliary body, as well as the zonules and the suprachoroidal structures. But it is something that requires a skillful operator. You need some time to perform the ultrasound scan, and there's contact required from this patient. In my center, the patient does this in a supine position, so that is yet another disadvantage of the ultrasound biomicroscopy. As I mentioned earlier on, what are the indications of ASOCT? You have the clear and the distinct advantage of using anterior segment OCT in my practice is to determine the mechanism of angle closure. And we all know that there are several mechanisms of angle closure nowadays, and you can use targeted treatment to address this. We can also look at the assessment of laser procedures. You monitor these chronic conditions over time, and you can also assess the position and the patency of glaucoma tube shunts and evaluate the anterior chamber, especially if there is corneal opacity. Let's take a look at these older scans. These are time domain OCT scans. You can't find them anymore. I don't think Zeiss produced the Vicente anymore, but these are time domain OCT. You can see that we have now moved on and used swab source OCT that gives you, number one, clearer resolution. You can see all the way down to where the Schlemm's canal is for some of these scans. You can also get quick 360-degree scans of the anterior segment structure rather than just one cross-sectional scan that the time domain OCT gives. So that gives you a lot more data, gives you a lot, gives you more data points to detect and monitor these patients with angle closure. Shall we speak a little bit more about the mechanism of angle closure, which I think makes sense, it's logical to me. We all know that pupil block mechanism is one of the key mechanism of angle closure. It is now increasingly shown that there are multiple other mechanisms of angle closure that you should be looking out for in your practice. If you draw a line from the sclera spur, and you can see that from the red line to the end of that pupil, you can see there is prominent bowing, right? This is what we call iris bowing, and that's because there is a differential pressure gradient between the posterior chamber and the anterior chamber. This is classic. And when you see this, like when you see a pupil block like this, peripheral anterior laser iridotomy helps to elevate this mechanism. But there are other mechanisms where the iris profile is a lot flatter. You can see over here in B and C. And these are typically plateau iris or thick peripheral iris. And these are mechanisms where maybe the iridotomy may not address these mechanisms. And I will show you examples how just by doing laser iridotomy for all of these patients with primary angle closure does not address and eliminate the mechanism of angle closure. And lastly, we are getting more and more data on the role of the lens in angle closure. You can see over here that the lens VOD is very high, and that's the main mechanism of angle closure in these patients. And removal of the lens may not be a bad idea to try to reduce the risk of progression in primary angle closure. And how about multiple mechanisms? Yes, of course you can get that. You can see this particular patient with both pupil block and increased lens VOD, right? So there's both mechanism over here involved. Both laser iridotomy and lens extraction will help this patient open up the angle and reduce the risk of progression. So this is multiple mechanisms. You can see the clear-cut example of how just by doing laser iridotomy without addressing and identifying the mechanism can make a big difference. Over here towards your left, if you look at panel A, you can see a patient with pupil block mechanism, and after a laser iridotomy in panel B, the angles open up. Because you elevate, you remove that pressure gradient, you flatten the iris profile, the angles open up. This is a successful laser iridotomy. I define success by opening up of the angles. But if you see to your right, another example of a patient without pupil block, right? Prior to laser iridotomy, the angles are closed. Guess what? After laser iridotomy, the angles remain closed, right? So there is residual angle closure. It just tells you that there are other mechanisms of angle closure that needs to be addressed in this patient. So by doing laser iridotomy alone may not be, I think in my center, when I train my fellows and my residents, I tell them after laser iridotomy, you can't quite discharge the patient. You need to monitor the patient, you need to follow up the patient and look and assess the outcome of your laser iridotomy. So allow me to introduce you to this mechanistic way of addressing the angle closure condition that the patient presents to you with. You can have primary angle closure to your left or secondary angle closure. If you can determine the mechanism, you can then have a more targeted treatment to that particular patient and help to improve and reduce the risk of them progressing through PACS to PAC to eventually PACG. Anterior segment OCT is there for a long time. It's nothing new. You have seen these complex images, I'm sure, right, through journals and even in presentations as well. These are probably not very friendly. You can hardly determine which parameters that you want to track or which one is the one that's more important. Can we make it more user-friendly? Can we make it more friendly to our practice? The answer is probably yes, right? In this particular situation, in the past, when you want to detect or measure certain parameters on anterior segment OCT, you have to manually detect where the sclerospur is. So that's problem number one. Can you detect the sclerospur accurately? Number two, is there variability, right? The same patient following you, seeing you over multiple visits, maybe over several years, may have different sclerospur positions, right? The person who is identifying the sclerospur may not identify it at the same place all the time. In this particular paper, we showed that it is possible to detect the sclerospur automatically through the use of AI, segment the images to cornea, anterior chamber, as well as iris, and then make the measurements in automatic manner. And what we hope to do is to come up with what we call a goniogram, right? So this goniogram allows you to detect and see where those angle closure positions are. Is it always in the vertical meridian? Is it always in the horizontal meridian? And once you diagnose the condition, you institute a treatment, you repeat this particular algorithm, you can see whether there is any improvement quickly in your anterior segment OCT scan. So we can reduce the number of gonioscopy that you do through the use of anterior segment OCT. How about predicting the outcome of laser iridotomy in these patients with primary angle closure suspect? Just using anterior segment OCT, we have also shown in this particular paper that what is the most distinguishing feature, what are the determinants of success of angle closure is down to three things. One is the angle recess, two is the iris curvature, and the concavity ratio. No surprise. I think I mentioned this earlier in my talk, that the iris profile or the iris bombay that determines pupil block is the mechanism that is being addressed by laser iridotomy. So if you look at the anterior segment OCT and you see this bowing of the iris, then you can be quite sure your laser iridotomy will help to address the angle closure. Let's go to this, back to this spectrum of disease of angle closure again. To treat or not to treat, right, in patients with primary angle closure suspect. Remembering they have no symptoms, they have no disease, they come here and sometimes you detect them through your investigations. The ZEP study has helped us shed some light on this for patients with PACS. So let me repeat that. These are only for patients with PACS, meaning no pressure rise, no anterior synechiae. And this particular study has shown that, for the interest of time, I wouldn't go through the details of this particular study. But in essence, the study, which is a 14-year follow-up data, shows that laser iridotomy does reduce the incidence of progression, right? Progression to what? Progression to PAC, meaning pressure rise or acute angle closure attack. But the number to treat, to reduce that is high. To reduce and prevent pressure rise, you need to treat 444, and to prevent acute angle closure, you need to treat more than 200 eyes. From the epidemiology point of view, from the purpose of a public healthcare setting, doing laser iridotomy indiscriminately without looking at the mechanisms is something that the paper suggests you not to do, right? But then I think I've mentioned just now, look at the mechanisms of the angle closure. So that's what the paper showed. Personally, when do I do LPI in patients with primary angle closure suspect? I do consider these factors. Firstly, if the fellow eye has acute angle closure attack, I do laser iridotomy. If this patient has frequent or require frequent dilated fundus exam, they have symptoms related to intermittent angle closure, they are living in an area where they cannot get access to healthcare, and once again, emphasize looking at the mechanism of angle closure. If this particular patient presents with PACS and has thick peripheral iris or has a lens vault, then I tend not to do a laser iridotomy. I won't touch too much on this in the interest of time. I think laser iridotomy is something that's being performed quite commonly in our practice. I'll just show a quick video of how this laser iridotomy is being performed at my center. We do sequential argon and YAG laser, 2-stage. And you can see over here we use the a contact lens to try to stabilize the eye. And the first part of the procedure requires the use of the argon. The purpose of the argon is a form of coagulation. Through the use of coagulation, you can reduce the risk of bleeding. You can see that we sight the laser quite peripherally. You either do it at 12 o'clock, close to 12 o'clock at 1 or 2 o'clock. I don't do it at 3 or 9. I know some people do that. And the purpose of the laser is to thin out the iris. And you can see over here that the iris is now starting to thin out. And you can see that the hardly any bleeding with this. Otherwise, if you just use the YAG laser, the risk of bleeding is rather high. I'll move on from here, and I'll touch a little bit more on the PAC as well, right? And how do we manage patients with PAC? And now I think because Bo is not here, so I have more time. Am I right? Got it. You can see that as I progress, I speak faster and faster and faster. Okay, so the EAGLE study has helped us and guide us in how to treat patients with PAC. Now, in essence, patients with PAC, meaning high pressure, PAS is present, but no glaucoma damage. My practice has changed through the EAGLE study, and even actually before that, our thinking is that removing the lens by experienced hands is a bit better compared to just performing laser iridotomy. And lastly, if a patient has established primary angle closure glaucoma, what do we do then? I look at two big factors. One is the severity of the glaucoma and the target pressure, as well as the medication burden and the tolerance to pressure. So looking at severity, if this patient presents with mild or moderate glaucoma with higher tolerated target intraocular pressure, you can perform either just phacoemulsification alone or with goniosynovial lysis, and some people have mentioned that goniotomy is also particularly helpful in this case. If there is big and huge medication burden, then cataract surgery with glaucoma operation is my target. It's my first choice of surgery. Needless to say, if the glaucoma severity is high, that means they have severe glaucoma and the target pressure that a low target pressure is required, then combined cataract and glaucoma operation is my go-to procedure. I would like to share this particular article from a close collaborator of mine in Guangzhou, who looked at comparing phacogoniotomy versus phacotrabeculectomy, and I repeat, in eyes with advanced PACG. These are patients that require low pressure after surgery, and they showed that there is the phacotrabeculectomy group is not inferior to phacogoniotomy group. In fact, they show that there is less post-op complication in the phacogoniotomy group and less intervention after surgery. Something to consider, something to think about. In short, in conclusion, in patients with PACS, the options include conservative. I'm beginning to do more and more of this. You can do laser PI if pupil block is the main mechanism, or you can consider early cataract extraction if the patient has cataract. If the patient has PAC, it's either laser PI or cataract surgery. My practice has shifted towards more of cataract surgery in this group of patients. And lastly, with primary angle closure glaucoma, you might and you may have no choice but to perform glaucoma surgery in these patients. With that, I thank you for your attention. I'm open to any questions. Thank you.
Thanks, Victor. Any questions from the audience? Just quickly, one question time before we go. Okay. Our next speaker, and yes, yes, Ganga.
Is there still a role for iridoplasties? When I was a resident and fellow,
I think the evidence of laser iridoplasty is starting to come down, and that there is also reports of PAS formation that is a bit more common, and also corneal decompensation. So I think looking at the mechanism, if the patient has pupil block, laser iridotomy is the way to go. If the patient has lens vault, remove the lens. Let's try to keep it simple that way.
Great, thank you so much. Okay, our next speaker, Dr. Fu Lilian had some visa issues, but Dr. Ng Wei Yan instead will be taking her place, and he will be talking on updates on myopia management. Wei Yan, thank you.
All right, good morning, everyone. So, Dr. Fu Lilian sends her regards, and she regrets that she's not unable to be here. So, I'll present on her behalf. And these are our financial disclosures. So, in terms of myopia management, so the mainstay of myopia management is the atropine low dose. As we know, there are many different types of atropine. And for the low dose section, it's mainly the 0.01, 0.025, as well as the 0.05%. And it's actually justified based on the ATOM as well as the LAM studies, from ATOM 1, 2, all the way to LAM 1, as well as the LAM 3 study that has just been published. So apart from the well-known efficacy of atropine, this is the LAM 3 study, and it's a 3-year duration with a double-blinded randomization trial. And so what it actually shows is that when we continue with the atropine treatment, overall the 0.05 gives the best result, and that if we were to continue the treatment rather than wash out strictly after 3 years, there is still further benefit. So that brings a slight paradigm change to the thinking of whether we should consider to start tapering the dose a bit earlier, or should we just continue to treat the patient for an even longer time. Right. So, but atropine is the standard. So right now there are actually a lot more other modalities that's coming out. So if we start off with a clinical case, so we have a 10-year-old Chinese boy where parents have high myopia. So this is a high risk of progression. And now the parents bring the child in because there's documented progression of myopia, and the parents are keen for something to be done. So if you can look at it, the vision now is not that good, 618, 615 with the current pair of glasses. That was actually made about 1 year ago. It was about 1:1 diopter in strength. And when we did the cycloplegic refraction, we can see that there is a change in the refraction. And that's also corresponding with a difference in axial length between the both eyes. So in this case, it looks like there is a real progression. And what's the options that we have? And this is quite something that we encounter quite frequently in the clinic, where there's significant anxiety to eye drops. So the children is very, rejects eye drops. So what are the other options that is available, right? So the first one that came out in the market is the defocus incorporated multi-segments. That is by Hoya, and it's called the Hoya MyoSmart. And basically, it has a honeycomb zone arranged in hexagonal regions, especially if we were to differentiate with the other new lens. This is a hexagonal region with the central clear zone. And basically, it helps to defocus the periphery so that it results in a myopic focus and helps to reduce or retard the overall myopia progression. So this is the 2-year double-blinded randomized study, right, that first came out to justify the use of the DIMS technology. As you can see, that there's a significant reduction against the control for both for those patients on the DIMS over 24 months. And overall, what they achieved is a 52% slowing of the spherical equivalent progression, as well as 62% slowing of the axial length progression. And overall, in terms of stability, against the control, it was a threefold increase in terms of stability. And a subsequent follow-up with a 3-year follow-up study of the double-blinded. So what happened is that on patients that were on single vision lenses, now they receive the DIMS because it has shown that it's actually pretty significant. And what we can see is that overall, for those already on the DIMS group, they do continue to have a sustained response where the curve is sort of on the same gradient, while those now switching over to the new treatment, they actually also showed that they do respond, right? So this is beneficial even no matter what stage that you start the patient on. Then next will be the competitor, which came out later. This is the highly aspheric lenslet technology, which is by Essilor and named Stellus. So as you can see, compared to the hexagonal distribution, this is more in a circular distribution throughout. And again, they have a central clear zone, and then they use the highly aspheric lenslet in the periphery to achieve that myopic defocus in the periphery. So again, a 2-year double-blinded randomized control study that came out to justify the use of the HAWK technology. And over here, what we find is that they actually had 3 modalities. One is the single vision, then they have the slightly aspheric, and then the highly aspheric, which is the eventual technology that they used. So it can be shown that the highly aspheric actually had the best response for both the spherical equivalent as well as the axial length. And that's why in terms of head-to-head, they eventually adopted the HAWK technology. And overall, there's a slowing of the spherical progression by 0.8 diopters as well as the axial length by 0.35 diopters, which is about 50% overall. And then again, similar to the DIM study, they went on with a 3-year study such that those who are on non-highly aspheric were then switched on to the highly aspheric treatment for the 3rd year. And as you can see in the dotted line, there shows that there is a slowing down of the effect, or rather of the overall progression. So even after switching over, there is some benefit that the patient can achieve. So overall, for the patients that went on full 3 years of the HAWK technology, there was overall reduction in rate compared to the control of about 50 to 52%. Right? And then this is my good friend Hui Tran, which this study is done for over 19 months in Vietnam. And what happened is that they tried to switch between the HAWK lenses as well as the normal single vision lenses, and to see whether there's any difference or not. So the first group is where they had the HAWK first, that means the Stellus, then normal, then Stellus, over 3 stages, each 6 months apart. Then the second group where they started with the single vision lenses first, then carry on with the HAWK lenses. And it shows that overall there's no significant difference and there's no significant rebound after you stop. Even though that the graph shows that slight change, but overall it's not statistically significant. So irregardless, patients, if they were to take off the HAWK and then they were to start it again, for example, if they damage the glasses, it actually still provides benefit to the children. And so back to our case, now that the child is growing up 2 years later and is keen to participate in active sports, things like soccer, so what are the options that's available? So as we know, contact sports, sometimes they might want something else that is something maybe a bit safer, that might not crack under trauma. So this is mainly called, the options are contact lenses. So the first one will be soft contact lenses, where they work on the concept of peripheral defocus. And the current 2 FDA-approved ones are the MiSight by Cooper Vision, as well as the Ability One Day by AccuView or Johnson & Johnson. And in general, they each have their strength. As you can see, the range for the MiSight is slightly greater, but the duration of wear that is required to achieve the effect is slightly lesser for the Johnson & Johnson Ability lens. And subsequently, we have the hard contact lenses. More difficult to wear, as you know, because they're hard contact lenses, so it needs a bit more coaxing and training for the child. And this is the autokeratology lenses. They are worn at night. And usually they have to be changed every 6 months to a year, because they get damaged, contaminated, or cracked. And overall, the stipulated range is about 6 diopters, as well as a cylinder of minus 1.5, beyond which sometimes we can still try, but it might end up being either uncomfortable because too much pressure because of the reverse geometry, or that it might not be sitting well. And overall, they need to have at least 8 hours of wear at night. So those who sleep late and wake up early, it might not be that suitable. So what's MiSight? So MiSight is the first one that's approved by the FDA in 2019. right? And then they have these concentric rings that result in the peripheral defocus so that they can actually achieve peripheral defocus to retard the progression of the myopia, right? So it's designed on a dual focus design as compared to the Ability One Day, which is the newer, slightly newer contact lens. Right now it's only approved for use in Canada, Hong Kong, and Singapore. So hopefully soon you'll be able to come to India as well. It works slightly different because it has the central, what they call the ring boost technology, where the central part there has a +10 diopter design, so that it causes a bit more defocus than the Cooper Vision lens. Of course, this can result in a little bit more blurring of vision, but based on our anecdotal experience, children can tolerate very well. So, as you know, the MySight came out earlier, so they overall have we have a 6-year data that is actually published. So, based on this, what do they see, right? So, overall, they basically have two groups. One is the group of children that had total of 6 years of treatment, and the second group that had no treatment for 3 years, and subsequently then switched over to the MySight and had treatment for the next 3 years. So as we can see, for those who had sustained use for the over 6 years, they did get a very good sustained response of slowing down of the myopia versus the control group. While the control group, once after the 3 years has expired and they switch over to the treatment, and they also had a good response. So overall, the slowing of the axial length growth was 52 millimeters for the group that had total 6 years of treatment, as compared to the other group where they only had 0.19 millimeters of saving as compared to the extrapolated norm, right? So overall, depending on what denominator you use, there's overall about 50 to 70% degree of slowing. And then this is the study for the Ability One Day, right? This is only for 6 months because it's a relatively new lens, and they are coming out with the 1-year data soon. So again, it's a double-blinded randomized study, and this is what it showed. So as you can see, they have many different modalities, of which the EE is the enhanced efficacy, the one with the central ring boost +10 diopter technology, while the enhanced vision does not have that central 10 diopters. And so from this, they came to a conclusion that by incorporating the extra 10 diopters in the center, it actually showed a much better result. So overall, head-to-head, they decided to adopt the enhanced efficacy with the +10 diopter within the coaxial zone. And overall, they were able to achieve over that 6 months only of a saving of about 0.1 millimeter of axial length, as well as less progression of spherical equivalent of 0.22 diopters. And so, coming to the end, how is our clinical management evolving? So, apart from having new treatment modalities, we have more options to consider. But myopia is not just about treatment or combination treatment, it's also about how we monitor the children as well. So in clinic in Singapore, we mainly monitor the children using cycloplegic refraction as well as axial length, right? But this is how we do. We're transitioning away, but this is how we used to do it. So it's a very manual process where we actually have to chart it along on the graph so that we can actually have a better visualization of what the numbers actually mean. So while this is good, many a times you can see there's a lot of estimation in terms of each box as well as the separation, and it's very time consuming and difficult to trace back, especially when all these are handwritten notes. And our center has now moved on to the electronic medical records. Right, so this is something that we are gradually shifting to, which is using technology as well as software to digitalize it such that we can then better chart, grade, recall, as well as to compare versus each corrected norm. Right, so what are the options available right now? There are mainly 2 options available. So on the left-hand side is the Oculus Myopia Master, as well as on the right-hand side will be the Topcon Maya system. So basically these systems, they help to collate as well as to aggregate all the data together, including axial length, anterior chamber depth or keratometry, and the overall cycloplegic refraction, such that they can then give you a better analysis compared based on their own risk ratio profiling, and so that they can compare against the age-corrected norm, such that we can then extrapolate it to what will be the final myopia destination if the patient remains untreated. Right. So finally, back to our child. So over 6 months, the child had 1 diopter of progression, right? What's the reason for that? So There can be many reasons. It can be either a true myopia progression, or it could be due to accommodation, but usually that can be overcome by either a cycloplegic or worst case scenario, atropine refraction. Inaccuracy of refraction, sometimes we can double check it. That's not too difficult. Of course, the last one is compliance to treatment. And so in this case, it's a true progression, and we can consider combination treatment. So it's important to explain to parents that outdoor activities and reduced near work or gadgets is the key factor to slowing down myopia, but we can also consider combination treatment. We need to coax the child. Some of the special techniques would be to instill the eye drops when the child is asleep so that we get less resistance. And also, then we can consider combination with other things such as contact lenses or specialized myopia glasses, right? So with that, the field of myopia is changing, all right, and we are getting more and more spectacle options available. Soon there will be the CARE technology as well as the dot glasses that will be coming up soon. Hopefully, in the next meeting, we can then have some experience with that, and we can then share with you our experience or our results as well. Thank you.
Thank you, Wei Yan. I just have one question just before, I know time is short, but I just wanted to ask you, so in general, let's say the patients have no preferences, what is your first and second line choice of treatment when they come in with myopia progression?
Thanks, Anna. So that's one of the key considerations that we have during our clinic when we approach the parents. So assuming that finance is not a constraint, usually if I would suggest to be a bit more aggressive nowadays, especially when we know that Prof. Mark Bullimore has said every diopter results in a 60% increase in future myopic maculopathy, and they will then need to see you, right? few decades down the road. So right now we are advocating for more aggressive treatment to slow down the progression. So usually I will start by offering the atropine first, and if they do not mind, then I will suggest for combination, right? Either with specialized glasses, the DIMS or the Hawk lenses, or with contact lenses. With the caveat that as the concentration of atropine increases, they do get some dilatation and loss of accommodation. Then that might curtail the ability to combine with the other treatment. But generally, I would start off with combination if the parents can afford.
Great. Thank you so much. And last but not least, we have... oh, sorry, one more question from the audience.
Yep.
Yes, please.
Usually we use cyclopentolate, and we combine it with phenylephrine, various concentrations for the children. So, but usually we go with cyclopentolate.
Great. So our next speaker will be Dr. Ganga Sundar, who will be talking on oculoplastic surgery, the East Asian perspective. Can we invite Dr. Ganga, please?
Thank you, Anna. It's a pleasure to be back. This is day 3, my 4th or 5th talk at the meeting. How many of you are oculoplastic surgeons? There's none? There's one there. Great. So then I'll try to do justice. Because if not, I can cut down a whole lot of stuff in just interest of time. So I've been asked to share how is practice of oculoplastic surgery different in our part of the world, which is Southeast Asia, which is a nice heterogeneous mix of South Asians, Southeast Asians, and East Asians. So I'm going to share some anatomical and surgical perspectives. Even though they've given me 15 minutes, I'll have to rush through things itself. So when you talk about East Asians, the standard thing they talk about is the double eyelid East Asian blepharoplasty. In the West, they used to call it Asian blepharoplasty, but Asians is a heterogeneous population extending eastward all the way from Istanbul on one end to Japan and Korea on the other end itself. So it's now East Asian, which is very different from South Asian, which is very different from the West Asian. But in the West, they still use the word Asian blepharoplasties for these patients. And you can see that there are distinctly obvious anatomical differences, as you can see in the various ethnic groups. These are my conflicts of interest, but nothing to do with the presentation itself. So when you look at the common surgeries that we do eyelid surgeries, lacrimal surgeries, orbital surgeries, and we are now not just ophthalmologists, we are not just oculoplastic surgeons. Our society is even called oculofacial society. We now look at the whole face as a whole. Thyroid eye disease is no longer a thyroid eye disease. It's an orbitofacial disease. So just so you know, we look at the whole face as such. And that's a world population. You can see obviously where the population is concentrated. South Asia, predominantly dominated by India, which has now overtaken China, and China is the other one. So these are two powerhouses for population growth, for the same time for diseases and with economy getting better, longevity, so we're dealing with a lot of pathology now in the growing elderly population itself. And again, is a population distribution both by nationality and ethnicity. So South Asian anatomy is very different from the East Asian anatomy. So what's the big difference? Number one, first we have to be aware that there are ethnic variations. Today we live in a globalized world. There's everybody born from anywhere at this point of time. There's no guarantee 20 years later they're going to live in the same place. Global migrations is happening. In the east and northeast of India, we now know the East Asian anatomy and pathology coming in. I'll touch a little bit about it. And with medical tourism, people are traveling to centers of excellence. So nothing prevents a patient from one corner of the world going to other corners of the world. We have patients coming all the way from Russia for retinoblastoma management and stuff like that. So it's very important that all of us are aware of the various variations. The first and most important thing is eyelids. So East Asian blepharoplasties used to be called colloquially as double eyelid surgeries. And that's based on the pretext that the anatomy is completely different. You can see there's an absence of the lid crease. You can see the pre-aponeurotic fat is not just pre-aponeurotic fat, but comes all the way to the pre-tarsal area as well. There's lack of adhesions, so on and so forth. In addition to that, there's epicanthal folds, premature brow ptosis, lateral hooding, and so on and so forth. And we do surgeries, various forms of techniques, and we find anatomy. For example, if you look at the bottom right, a standard anatomy textbook will say there's an upper medial fat pad, there's a central fat pad. But in our East Asians, we even find lateral fat pads. That's where textbook anatomy that we read written from the West or anywhere else may not always apply towards the East. These are common eyelid conditions you see in children, developmental conditions such as epiblepharon, and as they become young adults, you can start seeing, looks like bilateral ptosis is nothing but a lack of support to the lid in the form of a lid crease, causing a pseudotosis. And of course, elderly patients, you can see the lady on the right, where you can see severe brow ptosis, asymmetric brow elevation, dermatochalasis, ptosis, upper lid skin literally touching the cheek, and that's kind of patients we deal with. So you have to be aware that there's an entity called epiblepharon. It is the most common pediatric oculoplastic surgery that we do, and this is a developmental condition. It's not an abnormality. If you read a Western textbook, they call it an abnormality fold, but this is a developmental, racial, ethnic condition. And unless you stain them with fluorescein, we use 2% minims for our patients, you will miss this kind of keratopathy, and you wonder why these children are constantly blinking all the time, why they tear, they have photophobia. It's because of keratopathy, which oftentimes is diagnosed as chronic allergic conjunctivitis and so on and so forth. So these are examples of patients where we've done both an upper and lower lid epiblepharon correction. Yes, we do all functional surgery with an aesthetic touch. So to us, we are now not only getting rid of the lashes, rubbing the eye, we're giving them a pretarsal fold, eyes are appearing bigger, and the child also has a better self-esteem. So what about aesthetics? We don't stop just with the upper and lower eyelids. We talk to the brows as well. Of course, brows, people express themselves variably, but we are talking about normal brows. In East Asians, and if you look at them, sometimes they have very sparse eyebrows. And if you look at the forehead in any patient, and oftentimes ophthalmologists and ophthalmology residents and fellows only look at the eyelid, upper eyelid, lower eyelid, and that's about it. We ask them to look at the hairline and the forehead. Tells you how much effort they're putting in to try to treat the lash ptosis that they have with frontalis overaction. For the same reason, a lot of these patients have premature brow ptosis. So in our practice, brow lift becomes a significant part of our practice, which I don't see much happening in South Asian continent over here. So these are again patients who had upper lid epiblepharon with ptosis or pseudotosis, where again upper lid blepharoplasty gives you good results. So coming to the brows, this is an unaddressed aspect of the oculofacial aging changes, gravitational changes, and of course it runs in families as well. The ink mark that you see on the forehead is literally where the orbital rim is. It tells you how far down below the brows have descended. And these are patients where you will not be doing a blepharoplasty or a ptosis. These are patients who will deserving a brow lift first, and then only then you do an upper lid blepharoplasty. These are examples of patients where we do a direct brow lift. Notice how sparse eyebrows. Yes, there's a little bit of scar, as you can see on the side, but if you construct your wound very well and the patient heals well, scar is very minimum. So in our books, this is a very underperformed procedure in aging changes of the face itself. And this is an example of a staged rejuvenation of this patient. We're not making her look like Taylor Swift or something like that. This is like her making look better, younger, and more functional in society. So first stage was a coronal brow lift. After doing a coronal brow lift and stabilizing the brow, look at the forehead in the central picture, we've raised and stabilized, and then we go to a stage upper lid ptosis and blepharoplasties. The main complaint from the family was they could not keep this old lady at home anymore. She became so active that they could not keep her at home. So just to let you know how we can be serving our patients even better. And of course, in younger patients, we do endoscopic brow lifts. So quickly shifting gears to lacrimal surgery, how is it different? DCRs is quite popular. I know in India, they do a lot of lacrimal irrigation prior to cataract surgery, glaucoma surgery. That is the only way they usually pick up unless the patients have an acute or chronic dacryocystitis. In the past, the standard treatment was either an external DCR, but in our now what is really coming in a big way is endoscopic DCR. That's now the procedure of choice for most patients with NLD obstructions. But what is really new is endoluminal lacrimal duct recanalization. I did a keynote yesterday on dacryoendoscopy and ELDRs for these patients. Why is that important? East Asian patients have a far thicker maxilla. So if you, I don't know how many of you are from Calcutta here, Tripura, Mizoram, anybody, Arunachal Pradesh. When you see these patients, these people have a very thick bone, especially the younger patients, and dealing with the bone becomes very, very challenging. Putting a scar in the medial canthus becomes very difficult as well. They have a high nasal septum. They have a high sac in a lot of patients. Sometimes the patients are not fit for general anesthesia. So that's where, to deal with the big bone, you have to do various forms of instrumentation. I don't know if this video will work over here. So we either need powered instruments, and these are disposable instruments, cost $500 a pop for these patients, and that alone becomes far more expensive. Or if you don't have that, that's the skull base. You can see the metal hitting the bone. That's how thick these bones are for these patients when you're doing DCRs for these patients. So what that led us to is to developing microendoscopes and dacryoendoscopes in our practice, where we are now getting through 1 millimeter endoscopes through the lacrimal system, going down to the lower end of the nasolacrimal duct, and we are able to identify the level of obstruction, identify pathology intraluminally, and they are able to recanalize them. So if you're not oculoplastic surgeons, this may be the first time you're seeing the lumen of the lacrimal drainage system, all with these semi-flexible and flexible microendoscopes, which we use right now in the operating theater, and soon enough we're going to be offering in our office procedure as well. This is an award-winning video. Can you reduce the volume, please? How we do the ELDR. So this is being done in general anesthesia for recording purposes. Basically, we identify the upper and proximal system. This is the 3-port microendoscope that we introduce. After the, if you're doing it in the clinic, we do endoluminal anesthesia. We're actually passing down, and you can see this animation. As you walk down the canalicus, proximal and distal canalicus into the lacrimal sac, we are now seeing endoluminal anatomy, which in the past was a blind area, and we were managing all the NLD obstructions without really knowing what is inside the lacrimal drainage system. So once you recanalize, I use Tramson alone, and then you follow it up with either balloon dacryoplasty alone or with bicanalicular Crawford intubation system. So much so that we are now, with patient acceptance and education, we are able to offer this as an outpatient procedure for our patients. No regional infiltration. We use what is called endoluminal anesthesia, dilute local anesthetic into the lumen. The advantages are manifold, including patient acceptance. You don't have to deal with the bone. You don't have to do general anesthesia. You don't have to do local anesthesia, and you get fairly good outcomes. So much so that ELDRs have far surpassed the external DCR rates in our population itself. So last 2 minutes on orbital considerations. How is orbital anatomy different? The volume of East Asians is different. The lateral orbital rim is different. That's the reason why our Hertel's reading or Moritz reading is far lower than the Asian or the Caucasian population itself. And the deep lateral wall anatomy is also very different. By default, one of the most common orbital surgeries, at least here I would say, is thyroid eye disease with orbital decompression. Thankfully, the awareness of thyroid eye disease is becoming more and more aware. Even if you're not the oculoplastic surgeon, orbital surgeon, but if you're just an ophthalmologist, at least find out who manages thyroid eye disease better. But both in developed and developing nations, fractures are also a significant part of it as well. Now, these are the various surgical landmarks as well, you can see over here, but there are distinct anatomical variations in the aperture, the rims, the volume, and the sulfur, and that also affects the nasal cavity. And why is nasal cavity important? A lot of endoscopic surgeries are evolving towards transnasal endoscopic medial wall decompression, so on and so forth. In the interest of time, I'll just move on, but just to let you know, South Asians and East Asians are different. The anterior lateral rim is very different. The lateral wall trigone is very different patients. Orbits are far tighter. If you are giving peribulbar anesthesia 6-10 cc's, you can still get away with it. In our patients, I don't know, Victor, you know or not, you put 1 to 2 cc in an East Asian orbit, the orbit becomes rock hard. That tells you how tight the orbit and the orbital septum and so on and so forth. So in summary, what I tried to cover in the past 10 minutes or so was East Asian anatomy is different from a South Asian anatomy. So if you're the versatile surgeon, I believe in training residents who can be transplanted to any continent in the world and they should be able to pick up and run. Whereas if you say, I'm only familiar with this anatomy and I cannot deal with the other anatomy, I believe that we are all unprepared surgeons. Those of you dealing with patients from the northeast of India, and you know now people from northeast now are migrating southwards. I go to Chennai and I see what people from there. So no longer can a surgeon say, I don't know how to deal with the East Asian anatomy. Be aware of the ethnic variations and offer customized management. With that, I'll put in a spiel for our next exclusive, dedicated 3-day exclusive orbital symposium, full with cadaveric dissection, deferred life surgery, and so on and so forth. And I welcome you all to Singapore. Thank you very much.
I think, is there any pressing questions from the floor? If not, we're 5 minutes late, so I don't want to put the other session later. But if there's questions, we'll be staying back and we'll be able to take them offline. Thank you very much for your attendance today. And thank you very much for the invite from the All India Ophthalmology Society to our Singapore Society of Ophthalmology. And we hope to do more collaborative meetings together.
Maybe I know. Okay, one last question.
One
Is it
more
okay?
question? Yes?
He was talking about endoluminal anesthesia.
Yeah.
Can you please elaborate on it?
So traditionally, medial canthal procedure, lacrimal procedures, you needed to give the anterior ethmoidal block, you had to give the infratrochlear block, and so on and so forth. But where is the pain really coming from? From the lumen of the nasolacrimal duct. So we use a dilute local anesthetic, the dental cartridge, which is lidocaine with adrenaline. We dilute it 50-50 with saline, normal saline. So the 1% becomes 0.5%. So when you're doing your diagnostic irrigation through the upper punctum or the lower punctum, you just put a little small squirt of about 0.25 to 0.5 cc's from one side, quickly go to the other side, squirt a little bit on the other side. By the time you come back to this side, the lumen is completely anesthetized. After that, you do your probing. Assuming you have a decent punctum dilatation, everything that you do endoluminally up to the point of obstruction is completely pain-free. And you can push it a little further to try to get for recanalization as well.
Thank you. And the procedure is endoluminal dacryocystodynostomy.
Endoluminal lacrimal duct recanalization, ELDR.
Lacrimal duct recanalization.
And it can be done either with or without a dacryoendoscope, but that is becoming a big procedure in our lacrimal clinics. And Dr. Victor Ko has been very supportive of the procedures. We are now doing recanalizations that has dramatically dropped the indication for conventional DCR.
Thank you. It was a new topic for me.
Thank you very much.